The results suggest that this assessment tool may have contributed to participants' ability to screen, identify, and initially manage patients with inflammatory arthritis. The technology template created for this module may be used for future case simulations in randomized controlled trial. A current randomized controlled trial is underway and is currently in the analysis phase. And the first phase of the results demonstrate that the GALS screening for arthritis shows online group seem to learn at a better rate than the paper format. In addition, the ability to retain information over time seems to be better with the online learners. What was particularly interesting with this study as a proof of concept was that all healthcare providers, not just physicians, were able to successfully identify patients with inflammatory arthritis. And the importance of this is that you don't need to be a physician to identify inflammatory arthritis and refer to subspecialty care. Interprofessional teams may be on the horizon. In Canada, a national organization has been developed called the Canadian Interprofessional Health Collaborative, which has articulated core competencies in health professional education about being a collaborator. Cross-professional and cross-institutional programs are being developed and evaluated. An example of the interprofessional education is in the Department of Family and Community Medicine at one institution, where 4 IPE programs for pre-licensure and also post-licensure students from 8 to 10 different health professional groups who learn with, from, and about each other on certain curricular topics in their educational programs. It is important to note that all of these current programs involve interprofessional assessment and management of musculoskeletal conditions in primary care. The opportunity to impact healthcare delivery as a team is not unique and is practiced globally with high-performance athletes. Back in 1986, the opportunity to develop and implement an integrated healthcare team for high-performance volleyball athletes presented itself. Players were able to self-refer directly to the MSK physician and receive concurrent continuity of care among all healthcare providers for the sole purpose of advancing care for our high-performance athletes, both at home and abroad. This model was implemented in 1986 and adopted by Sport Canada thereafter for all centralized national sporting organization. This model of care is not unique to Canada, as many nations around the world are providing quality care for their high-performance athletes. My question to you now is, why can't every individual in society, no matter what the country of origin, be treated like an Olympian? How does this model of care, managing Olympians, differ from this model where a patient-centered approach is considered? In an attempt to determine if modifying the educational model to meet this patient-centered approach, we developed a new, broad-based MSK rotation and skill acquisition and are currently trialing this method with the rheumatology residents at one institution. We compare a control group of residents who did not experience the same rotation and learned in their usual fashion of reading around objectives and possibly doing selective experiences in orthopedic clinics. The hypothesis is a higher percentage of residents will perform better on both the qualitative and quantitative outcomes after exposure to an 8-week rotation than those not exposed to the rotation. This is a prospective study of first-year rheumatology residents exposed to this 8-week rotation versus those who did not get exposed and were graduating in the same year. The intervention will be an 8-week MSK broad-based rotation consisting of the ability to participate in a variety of orthopedic outpatient clinics, including spine, hip and knee, foot and ankle, upper extremity, soft tissue conditions, and the fracture clinic. Operating theater experiences, observing the initial intake assessment of individuals with MSK conditions of all kinds, and to follow one patient through the preoperative assessment process. Observe common therapies provided to individuals with MSK conditions by the rehabilitation team and other healthcare providers. Participate in the interpretation of MSK radiology imaging, including X-rays, MRI, CT scans, nerve conduction studies, and EMGs. And observe clinical encounters with physiatrists, sport medicine practitioners, dermatologists, and diabetes foot care. The opportunity also to present at orthopedic or rheumatology rounds. The analysis will consist of pre-post test measures, descriptive, qualitative, and quantitative outcomes, along with the evaluation of the rotation itself. The results of this study may impact the future education of rheumatology residents and may become a model for educating other residents, such as family medicine and even medical students. A similar model is currently being developed with outcome measures and applications that will be suitable for residents in orthopedics who also need to learn to identify musculoskeletal conditions before they actually operate on them. The evaluation model we would like to use is based on the Dixon-Kirkpatrick model, where we will first evaluate if learners are actually using a tool, and if so, are they satisfied doing so? Ultimately, are they learning from the process, and are they able to make applications to their real world? Ultimately, we'd like to assess if a change in behavior resulting from the learning process is implemented into clinical practice, and if so, what are the cost benefits of this implementation and the return on investment for doing so? Finally, we would be interested in how the learning tool actually impacts population health outcomes. So much has been accomplished over the past 10 years. However, there is much to consider with respect to the opportunities to improve on these achievements and may include the following. First, the fact that the time allotted to provide MSK-related educational activities appears to be decreasing. If this is the case, how will we then educate our medical students and other healthcare providers, and what is needed to identify and appropriately refer to subspecialty care? How will we manage as a medical community to deal with less time to educate our future healthcare providers? Second, the need to validate evaluation templates on how to really determine true competency of any skill. Third, how to implement MSK curriculum content into educational activities and clinical practice, and the ultimate transfer of this knowledge to practitioners in optimizing patient care. And fourth, how do we integrate effective use of interprofessional collaboration of all MSK healthcare providers simultaneously while respecting and considering patient safety, various scopes of practice, remuneration for service, team funding models, and ultimately accountability for patient care? How do educational research and medical education continue to be funded? Will clinicians of the future continue to fund academic work? Will government increase funding for such activities? What funding model will really work and remain sustainable for the next decade and beyond? I think it will be very important to consider, as right or as wrong as this statement will be, that compensation in some form or another most certainly drives behavior. I would like to thank you very much for your attention and acknowledge the following institutions and organizations, and in particular, I am a young investigator for the U.S. and Canada Bone and Joint Decade Young Investigator Initiative, and without their support initially, my academic career would probably be non-existent. So thank you very much.